Welcome. I'm Dr. Vinay Prasad. I'm a hematologist-oncologist, and I'm Associate Professor of Medicine at the University of California, San Francisco. In my professional life, I see patients, I teach trainees, and I do research in healthcare policy. This is Plenary Session. Plenary Session is a podcast at the intersection of medicine, oncology, and health policy, and you're listening to Season 3. On this week's episode. This week on Plenary Session, we've got Aaron Richterman. Dr. Richterman is an infectious disease doctor. He's at the University of Pennsylvania, and he has a lot to say about SARS-CoV-2. You won't want to miss this discussion. You know, normally every week you hear me say, if you're a fan of this show, go support us on Patreon. You get access to the slides. I got something new to say this time. I think the good old days are over. We're living in a unique time where people are very happy to extinguish voices and ideas that they deem unfit for consumption. And so I personally have gone on Patreon. I've supported a number of people who I listen to, the podcasts that I love, and I'm encouraging you to do the same. The only way we can combat this growing force of illiberalism is to support with our dollar bills podcasts we enjoy. So that's my plug. I'm back in Plenary Session, and I'm joined via Zoom by Aaron Richterman. Dr. Richterman is at the University of Pennsylvania. He is a card-carrying infectious disease expert. He did his medical school at UPenn. He did his residency at the Brigham, where he specialized in global health and did HIV work with Paul Sachs and colleagues. And he is now an infectious disease fellowship in the endless fellowship that is fellowship at the University of Pennsylvania. He's active on Twitter at Aaron Richterman. Aaron, it's a pleasure to speak with you.
Thanks so much for having me. Longtime
follower and fan of you on Twitter.
Same.
Oh, okay, good. Let's keep it that way. So, I don't know, where shall we start? You're an infectious disease doctor, and you have been working in the clinic this whole time. Is that fair to say that you've seen it all from March of 2020 to the present day?
Yeah, I mean, I've been across two health systems, one in Boston and one in Philadelphia. So I've seen the full gamut.
The full gamut. Yeah. So let me ask you, the first thing I want to ask you, case fatality rate, CFR. Did something happen between March and April, that first cohort, and the fraction of hospitalized people who passed away with SARS-CoV-2, and let's say November, December of 2020? Because when I've looked at some of these studies, it suggests that if you were hospitalized, your risk of dying has dropped. And I want to get at the explanation, because it's true in every single age group, too. If you're 70, if you're 80, it's not related to the at least the age of people who are presenting. Have you noticed this phenomenon?
I mean, I think it's really, really hard to get at that question, I think. I mean, you're seeing different people admitted over time with different sort of clinical loads in the hospital and different treatment protocols. I think it's probably accurate to say that the rates of death have gone down over time, but I think it's hard to know how much of that is different patients being admitted. I mean, when you have an entirely susceptible population and a lot of the like the nursing facility kind of patients getting really hit very hard early on with the very, very high fatality rates, who are going to be frailer than age-matched people just in general. So I mean, there's that potential component there, and then I think there are the treatment. There's the treatment component, which is probably not, which I suspect is not that much in terms of the beneficial treatments that we've got. I mean, we've gotten a couple that
how dare you
that seem to have have improved care somewhat, but I mean, if they're modest effects, probably something that we're seeing is like a lot less of the cowboy medicine that's potentially was harming people. I think a lot of people thought that this was something that was a completely alien disease, that principles kind of flew out the window in many regards. And so I think it's really hard to calculate or to quantify, what the downsides of that were, what the effect of that were. So I think, people, at least in the hospitals that I've been, have moved very much more towards more like, more disciplined medicine in terms of what they're doing. So I think that's probably had some effect too. So I mean, I think the short answer is I don't know exactly. I suspect there's probably some change, but I think it's hard to put exactly a finger on exactly how much it is.
Yeah, I've seen some papers from the NYU group, and I think another paper looking at this effect. I think there is an effect, but I think you're raising a good point, which is what is the cause of the effect if there is a reduction in death? I guess one point you're making, excellent point, is that there's something different about the patients. And even though you're adjusting for age, that's just one of the risk factors, there may be some other risk factors you're not fully capturing, or it's that of the first people who are 70, the first people who are 80 got infected, they might have been older, frailer, more likely to be in nursing home settings than the second wave of 70-year-old, 80-year-old people. So that's possible. The next set of characteristics you're asking is, our treatments got better. And in part, that was dexamethasone. In part, it was, the novel treatments we've had. Maybe it's in part sort of a better regimentation to how we're delivering care. The third bucket you put in was the bucket I like, which is I like to think about at least, which is, was there potential iatrogenesis from cowboy medicine, which is everyone's favorite brand of medicine, cowboy medicine, where you say evidence. That's for people who've got the time to wait for results. And we don't have the time for evidence. We only have 5,000 people here in this New York hospital, and we have to give them all full-dose anticoagulation because who knows when we'll get another 5,000 to randomize. We never know. So we just got to give them all the full dose. And that was the kind of cowboy, that was emblematic of the cowboy medicine we saw, which is this jack letter that I'm making fun of. And only because I think it's not really what you need in pandemic situations. You need randomized trials. So my question is, I wonder if you might talk about that cowboy medicine. So you were back in Boston. If I recall correctly, some of the hospitals you worked at may have had some hydroxychloroquine intrigue. I mean, I think I saw that on some of these forms. Were you in the hydroxychloroquine business early on in March of 2020?
I can say that I personally was never in the hydroxychloroquine
That's
business.
okay. Good.
And I think that there were, at least at the hospital I was at, it was never like a hard recommendation to do it. I mean, I think that there were a lot of considerations about theoretical benefits of a number of different therapies, including hydroxychloroquine. And so I think you would see variation based on which primary team you were kind of working with. And I was kind of helping out with the consult services there. So I think there was variation, and probably other places were more regimented in giving it to everybody, or giving azithromycin to everybody, or, uses of tocilizumab, or different, anticoagulation regimens at different time points, all that stuff. So where I was, I mean, I think it was, the treatment guidelines were not, we're fairly evidence-based, and I think gave a little bit of leeway for the clinicians themselves to operate within. But I can tell you I was never personally in the hydroxychloroquine business. I don't think I've ever given it to anybody.
I see. You were waiting for ivermectin, obviously.
Right, exactly. That's vitamin D. Vitamin D
and ivermectin. Yeah, vitamin D. I hear there's a new randomized trial of vitamin D. I don't know if you saw this. It's the typical randomization. You've got 8 hospitals. 5 of them do one thing and 3 of them do the other. Just your classic, randomized trial, classic randomization.
The typical method, of course.
Yeah, the typical method where you just say this hospital. I don't know why it's 4 and 4. That was the part that really stuck in me. So I guess all right. So I'm curious. You're out there, you're on Twitter, you're processing a lot of information, you're an ID doctor, you're increasingly speaking out. Is it a fair characterization for me to say that your confidence in giving your thoughts on an issue has increased over the course of the last year? You've gone from reticent to slightly more willing to talk. Is that a fair characterization?
Well, I think that, in general, one should, only speak publicly about issues that they've kind of done the background in.
What are you talking about? That's the wrong way. You're on the wrong website then. You're on Twitter. I'm sorry, my friend. You're on Twitter.
So that may have been why I was more reticent. I mean, I think as many people during this year, I mean, I've tried to do what I can to keep up on what's going on and keep up on the data that are becoming available, which is just it's a tsunami, really. And so, I mean, in areas where I feel like I have had the opportunity to review the data carefully, where a lot of, we're in a certain area where maybe other people haven't had the chance because of looking into other things, or because a lot of things are going on. I mean, I do humbly try to, put my thoughts out there. But, I mean, I think humility is the key to it all, because, there's a lot of things that we, in general think we know, but don't know. And there's a lot of things that have changed over the course of the year in terms of our understanding, both in terms of therapeutics and transmission prevention and even in terms of like, different things about the vaccines and whatnot. But the point is just, I try to, I put my thoughts out there, but I think Twitter is a good place to kind of have the back and forth and hear from the people that sort of disagree about that. And I've, had my own thoughts changed by that many times. So that's kind of where I come from in doing that, is trying to, have that conversation.
That's a very interesting point of view, because I think you sound like a lot of ID doctors I know, which is you follow that old credo, which is better to remain silent and be thought a fool than to open one's mouth and remove all doubt, which is something that is a good motto to follow. And it's something that I see people following when you have an in-person meeting. But it's interesting that the vacuum, the desire to hear something is great on Twitter. And so the vacuum will be filled with people who have their own way of interpreting evidence. And what is that way of interpreting evidence? I guess I would say many of the people who are interpreting the evidence for like the broad audience, some of the pitfalls I often see are, one pitfall is not really knowing the importance of randomization for therapeutic studies. I think that's just a classic pitfall. And so instead of randomization, they're happy to go with observational studies, which, many of us clinicians, particularly of a certain generation, we've moved away from those for therapeutics because we know how often they have been misleading, because those things are not deployed. The people who are similar to the people you gave the drug to are actually not similar to the people you gave the drug to, because that's why you didn't give it to them. And that's the crux of the issue. There's something different. It's just not documented, and you can't really adjust for that. Right. And there's time zero problems, which is always a problem with some of these studies. It's hard to pin down when the time zero starts. And so you have either immortal time baked in or something like that, guarantee time. Okay, so that's a pitfall, but it doesn't stop a lot of people. Ecological studies, which was, you saw a few of those, obviously. States where more people who fill out an Amazon survey say they wear masks have lower rates of COVID in some periods of time, and ergo one can plot sort of that classic ecological. And that's something that I think a lot of clinicians, not the kind of evidence we typically like to hang our hats on, that kind of wards where ivermectin were given do better than wards where ivermectin wasn't given. We're not in that business. Okay. The other challenge is, I think, faith in modeling. That's something different. I mean, as a doctor, you've had many patients in the intensive care unit, and often you have a wealth of physiologic variables, from what's their CVP to what's their SVO2 to what's their pulse ox to what's their and if you wanted to predict what someone's lung parameters will be tomorrow, their compliance, what somebody's pressures will be tomorrow, it's quite difficult to predict that a day in advance. You can model the hell out of it, and then you'll often be surprised. And so I'm wondering how you thought about this situation in March of last year, where you had the early reports come in, you saw that this was something unprecedented. What was running through your mind back then? And you're at one of the Harvard hospitals, so yeah.
Well, I mean, I think that the first real concerning thing that really kind of woke me up to it was that there was a New England Journal paper about the sort of transmission dynamics of the first 400 some cases. And that's when it was like pretty apparent just how transmissible this virus was, and that there was a fair bit of, there's a fair bit of serious illness associated with it.
Right.
So, I mean, I think that was when I got like pretty worried about what could happen from here. I think that no one alive has really been faced with something to that extent. And I think that, I would say, a lot of predictions were being made at the time, but I think that, when that paper came out, it was clear, like sort of the real dangerous potential of this pathogen. So, I mean, that's what's sort of going through my head at that point.
And you're rounding this time. You're on service.
Yeah, I was actually, when the news of this was kind of being spread around, I was in Haiti at the time, in a hospital there, and they were the people in this hospital were extremely worried about this, and doing a lot of preparation, for themselves. And I was like, is this really something that's going to make its way here? Like, is this kind of well founded to be concerned? And I think that it was shortly thereafter that paper came out, and then I was back in Boston, and then I was doing an outpatient clinical year where I was focused on seeing all outpatients for the most part, but pretty soon that was completely transformed, where patients were coming in, or everything was virtual visits, and then the hospital that I was at was completely overtaken by pretty exclusively COVID cases, among half of whom were critically ill. So it was, that became the 7-day-a-week existence for a while.
Wow. That's fascinating. Yeah. So you were in Haiti at the time when many TV pundits in this country were saying the best thing you can do for COVID is get your flu shot, because flu is worse than COVID, right? That was what they were saying. Yeah, they're like, flu is way worse than COVID, obviously, because there's more of it at the present moment in time. And that was a bit of
your risk from flu in the next 5 minutes is greater than your risk from COVID.
Yeah, in the next 5 minutes.
Don't worry about it.
Interestingly, folks who made those kind of comments, which you can pull up the reels, they're quite it didn't affect their credibility, in the sense that they're still many of them proudly giving advice on Twitter, on TV, telling us exactly what it takes to get us to where we need to be, which is obviously COVID zero. I wonder if I might pick your brain on COVID zero. Now, COVID zero is a sexy idea. I mean, I think it's fair to say that neither of us wants COVID to be there. We don't want COVID. We wish it weren't there. If there was, I always tell people, if I could strangle that bat that gave it to us, I would totally strangle. That pangolin. If I could find that pangolin and go back in time, I would. The pangolin's not coming out of that cave. Let's put it that way. So, but we can't do that. We can't go back in time. We are where we are. What are your thoughts on this as a strategy, as a vision? I mean, it sounds great, and in fact, a couple nations are, they're nearly there. I mean, when the world shut down, Australia was, maybe 2 weeks behind before where the U.S. was. When we all shut down, they had the advantage that there hadn't been as many cases, and so they could potentially, quelch what little they had. When we shut down, there had already been a certain amount of transmission, and now we're in a situation where, things are getting better, but we're still 70 grand cases a day. What are the prospects of this COVID zero to be achieved in a country like this? And I don't know. And sometimes is it possible that if it's not achievable, but we still aim to achieve it, is it possible that we may make policy decisions we wouldn't make if we tried to aim for something more achievable? What are your thoughts?
Yeah, I think that probably, certainly when this pathogen was first emerging, elimination was a very reasonable approach to take off the bat. And I don't think that, globally, we as a world, did that. Some places were successful in closing their borders and doing that, but in general, we were not aggressive enough early enough to make that feasible. So, I think at this point, the reality is that I don't see a way in which COVID can be eliminated, really. It's so transmissible and it's so widespread, that, it doesn't really feel possible to me. So, I'm happy to be surprised by that if it ends up being possible.
If they eliminated against your wishes. No, I mean, you mean against your best speculation that they could do it.
Yeah, exactly. I mean, I would be happily surprised by that. But I mean, this is there are very few infectious diseases that we've successfully eliminated. And I'm not sure that this is going to be one, but maybe. So I think the question then is like, what is I think given that reality in my mind, I think there's a couple like kind of principles that I would think about the policies with. I mean, the first principle, kind of as we've talked about, maybe this is obvious, is that like, yes, COVID is like really bad and it can cause really serious disease, and, public health measures that can, improve public health vis-a-vis COVID through reduction in death, through reduction in serious illness, and, more proximally through reduction in transmission, in a serious way, are important to pursue. But, at this point, we know a lot about the transmission of SARS-CoV-2. We know a lot about how it works. And one really important feature that I come back to again and again is that it has overdispersed transmission dynamics, meaning that a very small percentage of the people who have infection end up causing most of the secondary transmissions. So 80% of the infections come from 10 to 20% of the people. Mm-hmm. So, these are like these super spreader type events that are very typical of this infection. So when you have this transmission like that, you have very, very high yield at public health gains by doing what they call cutting the tail of the right skew. This is a right skewed
that's a good point, right?
Distribution.
So cut the tail.
So if you can cut the tail of that, and you can get rid of these very high secondary transmission events, then you have a very big impact on the, your goal, which is public health.
I've heard of flatten the curve. I didn't hear cut the tail. Cut the tail is a new one to me, but I like it. It makes a lot of sense. It's as referred to in the literature on this, but yeah, I mean, I think you have to think about what are the characteristics of transmission events like that, and we know what they are. 50 people get it, right?
Yeah, or just because most infections lead to no secondary transmissions or one secondary transmission, whereas a few lead to a lot. And there's very common characteristics. These are indoor events. These are people who are very early in infection. Mm-hmm. They're poorly ventilated areas, not wearing masks, and so you combine all these things together, and that's where you get it. And really, if you knock off like any of those things, then you really can kind of not eliminate, but really, really drastically reduce that. So I think that focusing that zero COVID is, in my mind, is not a reality that we have in this country right now. I mean, I think if we were in a location where there were a couple cases, then maybe you can and maybe we'll get there someday with vaccination where we can have that kind of approach. But then maybe you can, bring to bear the public health resources to really focus on bringing those down. I mean, thinking about if you want to make a comparison, you have Ebola reemerging now in certain areas of West Africa. And that is the approach that needs to be taken, massive public health resources to nip that in the bud. But right now, when something is raging out of control here, I think we have to focus more on those cutting the tail type interventions. And so the last kind of principle that I would think about with this is that, we're dealing with human beings, and human beings, there's only so much you can ask of a human being that they're going to do. You could take everyone and say, go sit in a closet and have food delivered and never go out. But I mean,
have you tried shaming? Because I hear that's the ticket.
Exactly.
Just a little more shaming and blaming. Yeah, then you get it.
Yeah, exactly. So, shame and stigma obviously are going to not accomplish what you want to do.
It has some effects. It has some ceiling. I mean, there's only so much you can get shamed. Yeah.
So I think the reality is there's only so much you can ask of people. So I think what we need to ask of people are things that are really going to make a difference. And are going to get at cutting the tail. And I would make a distinction between, people, what are we asking of individuals, and what are we asking of institutions? Institutions and governments where a lot of resources can be brought to bear to do really meaningful things to empower and inform people. So I think that, the zero COVID type approach, I think I don't know if it would imply a different set of policies. I mean, it would imply an expanded set of policies that, that some of those additional policies are probably going to get diminishing returns when you have 70,000 cases a day.
Right.
And, some of those policies may misdirect or redirect resources from other things that are going to be really, really high yield that we're really just not even doing that well right now. Like they're a year into this, there remain low hanging fruit, which unfortunately, that's the story of the epidemic in this country.
I think I was looking into their literature on zero COVID, and I was trying to think, practically how is it different than a harm reduction philosophy or minimizing total damage from the virus kind of philosophy? Both people want to vaccinate quickly, both want to do, they have a lot of things in common. But the only thing I could see that kind of sticks out as a potential difference was there are some people who advocate that, the key to get us to where we can pounce onto a zero COVID situation is a new type of lockdown where we lock down like we did last March, but even harder, not super long, but really hard, really hard. And I was like, yeah, I mean, in theory, it's terrific, but the practical aspect of it is a politically divided nation which has many firearms, and you're going to ask a bunch of people many of whom are just totally sick of it, to lock down harder than they've ever locked down before. That ain't gonna happen. It's not gonna happen. People are not gonna do it. You're gonna have to put the military in the street, and then I even think that they're not gonna do it. I don't think it's doable. I think it's just.
And I think the other piece to that is that the reality is that a lot of people have already modified their behavior insofar as they can.
Right.
And I think the it's the exception more than the rule of the people that are just throwing their hands up and saying, screw it, I'm just going to do whatever I want. I think saying that's kind of where, the terminology around a lockdown is sort of misleading, because I think that, there's, at the end of the day, there are still these quote unquote essential workers who, tend to be from poor neighborhoods. They tend to be poor. They tend to be racially minoritized, and they tend to be in jobs where they have higher exposure risks.
Right.
And that's where a lot of this epidemic is occurring. And none of these lockdown sort of measures are really
aimed at that,
impacting them to a large extent. I mean, to some extent, perhaps, with things like indoor dining and whatnot. But I mean, if you think about one example that I think is really sort of illustrative is if you look at, nursing facilities. There's a really interesting analysis of the nursing homes in, I think it was in California, where they looked at case rates within the nursing homes. They looked at sort of a network analysis based on cell phone data around, what the activity was between their nursing facilities. And they found that a lot of the largest, case numbers within the nursing homes and a lot of the worst outcomes were in places where it seemed that there were a lot of the workers there were sort of contract workers who were working multiple jobs and traveling between facilities. And, I think that highlights to me that rather than, sort of imposing a lockdown, I mean, what about thinking about those,
right,
these low wage workers who probably if they get sick, they come to work,
right,
they don't have a choice. So it's you tell them to stay home, you tell them to not come in when they're sick, and, they have to come in and go to work. And because that's sort of the system that we live in. So, I mean, I think an approach focused more on those kinds of things, which really are the origins of these larger outbreaks, where you have people early in infection who are going into congregate settings, that kind of thing, is probably going to be much higher yield than doing something like a super lockdown, where, most people who are already sort of working from home or able to isolate, or, that's not going to change for them per se. I don't think.
I think what you're articulating is a exceptionally good point, which is that, and really what I think public health means, the first thing you do is you figure out where the hell the virus is spreading. And once you figure that out, and insofar as that's spread by, and some of the things I've read are similar to what you're saying, which is that some of the spread is due to people who, through no fault of their own, have had to work during this time. They're the people who prepare the meals that we happily get in our Uber Eats. They're the people who are doing all the renovation projects that I keep reading about. I was just reading the Wall Street Journal, and they're in order to make whatever it's called, school from home better, we had a $200,000 renovation project on our house. I was like, oh, well, wonderful. That's just what everyone should do. Everyone should do that. Oh, it'll make it so much better. I was like, well, yeah, but somebody's got to do that construction work, and those people are actually at quite high risk. And so what you're saying is that you take some amount of money and you provide it so that if you are a construction worker, if you're a line cook, and if you have a fever, you should not feel obliged that you were going to lose the day's pay, lose your livelihood by calling in sick that day. We haven't done that. And meanwhile, we haven't done that.
And it's not even just feeling okay about it. It's about aligning incentives,
yes,
right?
So that you're incentivized.
You should be incentivized so that what the best outcome for you as an individual is also the best outcome for the public good. Rather than now where it's like kind of an individual responsibility kind of thing where it's like, okay, like, if you're sick, stay home. Okay, like, figure out how to get a test by calling 10 people and waiting in line and all this stuff. And nothing is incentivized to people have to swim upstream to really fight against, to get to a point where, the public health is being benefited by the way that they're responding. So, you can't blame anybody for the way that this is going down based on the way the incentives are in line. It's just wild.
I think that, that's one of the things that just gets me, which is that it just really gets me that, exactly what you're saying is the right answer. Okay, now I wonder if we might talk about the biggest challenge we face, schools. Now, some would have it that you never need to go in person to get educated again. Apparently, this type of format is perfectly acceptable for indefinite. No, I say that facetiously because obviously this is the shittiest way to educate somebody is through Zoom. It's not a good way to talk to somebody. I guess I don't even know if it's better than telephone. To be honest with you, if you have a clear signal on a phone, like that's the gold standard. And then like crackly Zoom is like the silver, and if you can't be in person, obviously the gold standard is in person, but then like a crisp phone call versus Zoom, there's some trade-off there. Okay, how do you think through an issue like schools? When you go on Twitter, it turns out that the answer is clear. Never have. No, the answer is clear. It's shifted. I feel like the narrative is shifting, and I've played a role in pushing on what I think is the right answer. But I mean, how do you think about it? You must think about this question.
Yeah, I guess there's so where to start with this issue. I would say first of all that just like outside of this whole pandemic thing, education, especially early childhood education, is one of the most, if not the most essential function of our society. It has the biggest return on investment, and it's just a truly, and I think everyone agrees with that. I don't think anyone doesn't agree with that.
But to be fair, you have actually done. You're biased because you've done 28 years of education. Isn't that right?
That's true.
You've done 28 years of education, so you're partial to education.
I've got my bias, that's for sure. But I do think, especially for young children, that it's really an essential societal function. And I think I've got some friends who are teachers, and I really, really admire the work, because the reality is that teachers are not valued for the service that they do to this, for the service that they do for our children's country. They're really, really undervalued. And I think that shows chronically in the ability to retain and train teachers and to, give quality education in this country. So, I'm very, very sympathetic to the fact that teachers have been just chronically undervalued in that setting. So now, in thinking about like schools in this setting, I'm going to sort of display my bias here, which is that I've been working in the hospital for the last year, and so I have,
entirely via Zoom.
Entirely via Zoom.
No, you're in person.
Exactly.
You're in person. You're in person.
So in person in the hospital, and I have just seen that it is possible to control transmission of this virus.
Right.
When I remember back in March and April reading some of these cluster reports from China, and there was one really memorable report from South Africa, one of those can't remember exactly when it was from, but it was a hospital in South Africa where they had a massive hospital outbreak.
Nosocomial, terrible. And it's like
it's
a cruise missile. It just destroys everything. It's terrible.
And and you look in, long-term care facilities and stuff, and you can see the really, truly cataclysmic potential of this virus in a congregate setting. And so, I think everybody in the hospital was very, very rightfully worried about this. Yeah. But the reality is that we've come to a place where I think most of us, at least in the hospital settings that I've worked in, where there's been careful attention paid to infection control measures. I felt really, really safe there.
Right.
And there's no social distancing really. You're seeing sick patients every day, and I think that it just seems like there's that hospitals were able to go from one of the most dangerous settings for this virus to one of the safest, where I felt completely safe. And of course, it's not eliminated. The risk of transmission is not eliminated. But, I've seen the occupational health data for these, hospital systems, and it's really, really, really encouraging.
Yeah, can you talk about that? So the precautions basically are slightly less staff on site than usual, ventilation insofar as possible. In one of the places I work, that is literally meant cracking the window and no additional ventilation. It's a 1920s building. Mask usage, universal mask usage, and then we don't shake hands, we don't hug, we don't get very close. And with those precautions, surgical mask, not the cloth, whatever. But the point is that outbreaks are, incredibly rare. We're talking about far less than what. Yeah.
The one thing I would add to that list is that, in line with what we were talking about before, is that people are really, really incentivized not to come to work if they're at all feeling ill.
That's true. Okay? And that's different than medicine, because for many years in medicine, the mantra was, unless you're dead, you better show up to work. And that I've always been suspicious about that. But now finally we have some sense. Yeah, if you're feeling sick, you don't come to work.
So I think that between that, really anyone feeling like even a little sniffle, you're staying home until you can be ruled out. And some of the features that were already sort of a part of a hospitals, with the ventilation and whatnot. So, that didn't change per se. I guess some places open windows and things like that, but, hospitals are pretty well ventilated structures for the most part, at least in this country. Sure. And then universal masking was the big change. And so I think that, in the setting of the current era of precautions, if you look at the majority of transmissions that are investigated by the infection control team, they can either be traced to the community, or they can be traced to, maskless face-to-face encounters in the hospital, people eating lunch together, or people being in a crowded workroom together and, eating, things like that. Or there are very rare occasions where you see like a weird transmission of someone who was like, very early in infection and self-suctioning and kind of doing that kind of stuff. So, there are always going to be the one-off transmissions that happen. Nothing is 100%, but it's gone again from one of the most dangerous places to one of the safest. And so, I think it's a proof of principle that it can be done. And, I think if the resources are committed to doing it, that it's not going to eliminate every single transmission, but when you have an essential societal function being performed, I think you make the effort to put that together. Now, so that would be my take on it. I'm not an expert on all of the school data per se, but there's fundamentally in my mind, there shouldn't be no reason that we cannot get to that. It's not a magical virus that is going to behave in some crazy different way. If anything, it seems like children may be a little less likely to be infectious. Yes. But even putting that aside, my bias from the hospital setting is that we should be able to do this.
You made this point well online, which is reviewing this data that the hospital has become. I think you're right. It's been transformed, and it was transformed with not a whole bunch of things, but really sort of common sense things. Luckily, a year into the pandemic, we did the kind of research that we desperately needed, the important research, which is that we took a mannequin and we put 2 masks on the mannequin. And the mannequin is really doing a lot better. That mannequin, I don't know if you know, the mannequin is now capturing 90% of the particles that are sprayed from an aerosol generating spout in its plastic mouth. So that's the research that, you don't want to do that research early in a pandemic. You want to give it a good year before you do that kind of research, because, it's the kind of research that's going to be so impactful. If you told people all at once, 1, 2, they can handle it. You got to give them a whole year to think about it. When I read that study, I was like, what are we doing? Why? I guess I was really, I was offended in so many ways. Like, yeah, I have no doubt that 2 is going to catch more particles than 3, and 4 will do more than to 3. In fact, you can titrate it until your ear is about to break off, or until your pulse ox literally goes down, and it'll probably catch more. That's a good do. But I guess what really offended me was the fact it took a whole year. And I was like, this mannequin, somebody's been sitting on this mannequin. Not literally, of course, they had the mannequin in the office, but somebody has this mannequin, and they didn't do the study for a whole goddamn year, and now they did the study. Okay, and then there's another call that was like, send everyone an N95 and COVID will go away. And my part was like, have you worn, I was like, listen, I've worn N95 to do bone marrows and such. And I'll tell you, you wear an N95 for 90 minutes while you try to do something physical. And I mean, the beads of sweat just just dripping down and it just cutting into your face. I mean, when you're really wearing it right? So you really want to avoid. Okay. Anyway, I guess the question I was going to get to is, I don't know where I was going to go with this, just to make fun. I was just going to poke fun at these things, but I guess, I don't know, to some degree, you're a proponent of masks, but you're sort of a sensible proponent. Like, I wonder if you might talk to your philosophy. What's your views on it outdoors when you're running? What's your view on it when you go to the grocery store? What's your view on it when you're in the hospital? Are these settings different? How do you think about it?
Yeah, so I'll return back to like that, my sort of first principles about thinking about this, which is that, really from a public health standpoint, what we really need to do are cut those tail events. Okay. And so really, outdoors, there was a systematic review of transmission of outdoors. It was in Journal of Infectious Disease. It's pretty good in the last month or two. And, there's basically been, it's been basically, I've never seen a convincing, like, case of transmission. I'm sure it can happen.
I know, but they're all like mixed. Happen. Like you're in the house and then you go outside and you spend time in both. Yeah, they're all. Yeah, I'm sure it can happen. Yeah.
Of course. Why couldn't it happen?
If the canopy is low, if you're in the bushes and his air isn't stagnant. No, but it's really low.
It just doesn't really happen.
Yeah, right.
And if it does happen, it's extremely rare. So
sure.
So, I think adding any additional mitigation at that point, is probably marginal at most. So I think then you're kind of exiting the realm of public health and you're entering the realm of like, personal risk tolerance. Okay. So like if I'm talking to someone and they're like, look, like, my number one priority is to like not get this at all. And I have to go to a grocery store once a week to get my goods. If then like, that's not public health. That's like their own personal protection. It's like, okay, put a face shield on, put an N95 on for, to get every last particle, wear it correctly while you're outside. And like, that's your personal goal. But like from a public health standpoint, I don't think that the marginal benefit from that, once you're past kind of those cutting the tail type events is going to be super helpful. So just to return back to the mask question, I think, and again, this is my bias, which is hospitals and seeing the kind of transformation of hospitals. And the reality is they've used surgical masks. So I think, I don't know. There's not a lot of good, better evidence to base this on, but they use hospital masks, medical masks as they're referred to in the literature, and that's been effective. So, I think that's probably a reasonable, something equivalent to that is probably a reasonable thing to do when you're indoors with other people from outside your household. Sure. That just seems eminently reasonable to prevent those, larger transmission events. So beyond that, then I think you're entering the realm of, like these experimental mannequin studies and like things that are more theoretical. And, of course, I think the more particles you prevent from entering your mask, I think that there may be a benefit in some situation, that we could imagine. it's probably not going to be that many situations, or else we would be seeing lots of transmission in hospitals and things with people wearing surgical masks. I saw this. I saw this tweet at one point that was like talking about the choir super spreader event,
yes,
right?
Yes.
And and there was
they sang with gusto.
And so there were a huge percentage of these people became infected, and I think they had some tragic outcomes. It's a really horrible but illustrative event. And so there was a claim made that like, well, if they had all worn cloth masks, then like 75% of them would have been infected. If they'd all worn surgical masks, then 50%.
Yes,
like these very these claims, exact,
yes. Very precise.
And I was just like, well, has there been any, if all of them were wearing surgical masks, like, has there been any event where like 50% of them got infected in a room? Like, that just seemed really high to me. I mean, I think it could happen. And of course, if they're singing and there's lots of aerosolization and things like that,
I guess.
But I mean, to just claim that there would be 50, that just seems unlikely to me.
There was an El País infographic that really got into the weeds. It was beautiful. This infographic blew me away. If I could make infographics like that, I would be successful. But every number in that graphic was probably spurious. I mean, it was really overly precise. But I mean, I think the other thing you're making a point is, I mean, I guess if you were really going to assemble that many people and pack them in so tight and get them to sing, I just can't imagine. Like, I just think either they won't consent to do that, or they won't do that with Matt. Like, there's two different groups of people. The people who sing right in the middle of a pandemic, they're willing to have a good old fashioned sing. Yeah. Well, I mean, I'll just tell you I haven't admitted this publicly, but I'm willing to say on the record now, if I'm exercising outdoors, I don't believe in the mask. I just don't. I was like, I mean, I can't. There's just no credible data, and I just can't. And it's like, and ironically, that's the one situation where people are most on the hunt, and I see them running, and I've seen tweets where somebody said, some of these people, I'm really impressed. Some of these, they're older than me, but older professors, and they're really running. I mean, 20 miles, 15 miles. I can't imagine I can't run that many miles. I'm not that good. However, they're doing it with like a bandana on their mouth and a big mask. And I don't know if you're helping anybody. Unless, I mean, you're not running through a crowd, unless you're running in the middle of the woods. This is the world.
I think you're reaching really marginal benefit at that point. And I think if you want to do that, more power to you to do that. But it just doesn't feel like one of those public health recommendations that, getting back to this principle that there's only so much people can do. And that to me feels like something just let it go, because it's
there's only so much people can do, and the tank is, and in this point in time, the tank is running on E. So the last thing I wanted to talk to you about is vaccine messaging. The vaccines are, I don't know if you know this, that the mRNA ones are 95% effective. So apparently what that means is that 5% of people who get the vaccine are destined to get SARS-CoV-2. No?
Right.
I was like, so there's this issue of numeracy. Right. So that's right. They're definitely going to get it. There's 5% of people, 1 out of every 20 are going to get it for sure. 95% effective. 95% effective, but the baseline, of course, in some of these studies is like, 2-3% over the course of 180 days, something in that ballpark. I got myself in a bit of hot water because, I don't know, it was initial sort of a reaction where, I don't know when the first time I saw it was, but it must have been, maybe late December, early January, but I'd never seen it before, but I started to see the message that was like, even though you've been vaccinated, you ought to live your life as if you haven't been vaccinated. So if you weren't going to hug your grandkids before, you ought not hug them now. And the more I just couldn't really wrap my head around that, because there are not too many interventions in life where there's a 19-fold reduction in the risk of an event and you literally don't change your behavior thereafter. That's just doesn't happen that much. And then I sort of did some back of the envelope things. I look at Moderna's study, and after the 2 doses, at the time of dose 2, so before dose 2 even kicked in, before you get that 14 days, at the time of dose 2, the absolute PCR positivity incidence in the vaccine arm is like roughly 1 in 1,000, and you already got like a 60% reduction. For asymptomatic PCR swabs, And who knows what they're swabbing and how many cycles they're running. They're running 40 cycles, 42 cycles, 45 cycles, God forbid. No, I don't know how much the cycles they're running, but my question is really, what percent of those people are truly infectious? I don't know the answer. Are they? But I do know one thing, that that of that PCR positivity, very little of it is going to become symptomatic. And I know that because the trial has captured that endpoint. So a lot of that is asymptomatic, that is going to stay asymptomatic, not the pre-symptomatic, which might be a different beast. So anyway, so I looked at that, and then I looked at these household contact tracing studies, which there's so many of them now, and I say, let's say, I don't know, 10%, 15% of people, like if you and I live together, I have a 15% chance of getting it if you have it. If we're living together, like we're in the house together. And so then I start to think like, okay, what's the chance?
Even among spouses who are sleeping in the same bed. Well, it's not that high.
Yeah, it's not that high. It blows me away. I mean, they're literally living together, right? Yeah, and it's the majority aren't going to get it, right? Okay, that's when you're in the put together. So what if you just hug them once at a dinner, for dinner after you've been vaccinated? So I discount these things by an order of magnitude. I don't know if people like that, so I do 1 in 100. And anyway, so I get all my probabilities and I start multiplying it out, and then I do some back of the envelope stuff, like an unvaccinated person goes to a Kroger and there's a lot of people there. There's some non-zero risk. People have been flying. We can quantify that risk. So there's certain things that we are okay with doing, and there's certain things we're not okay with doing. And I'm trying to see, like, is our emotional valence proportionate to the numerical risk? And everywhere I do it, I find that it's just not. It makes no sense. And then the last thing is, like we've got all these mask studies and they have, we can debate the effect size. We know the effect size isn't a 50% personal protection reduction because of the Danish mask, but it could be 15%. It's not powered for that. But it ain't 90%, and then nobody knows the effectiveness in the setting of somebody that got the greatest damn vaccine I've ever seen. I mean, not the best. But one of the best in terms of efficacy, just really off the charts good. And this flu vaccine that we get year after year, it's just trash compared to this vaccine, right? Yeah. It's just, Natalie Dean, the statistician, I like her. She had a great tweet where she showed how we calculate flu vaccine effectiveness. And I know this because I used to teach a class where we have these debates, and this was the topic one year, so I got into the weeds on it. And it's just so crappy. Like, the methods are crappy and the effectiveness is Anyway, so all right, so I look at this vaccine. So anyway, so then I wrote my little thing. David Aronoff wrote the rebuttal, and then I believe I tweeted about a bear, and in my narrative, so I wrote my article saying that, like, you can have some concession. I got a lot of pushback online where people thought I was, I don't know, maybe I'm a pro-death. I'm a sleeper cell. I've spent all these years doing all this work to suddenly come out as being pro-death in this moment. But that was an allegation that was tossed my way, and all other sorts of allegations. Ran the gamut, really. And so then I just wanted to point out to people that, like, none of us really lives a zero risk life. We all have some risks we do take happily. And if we didn't take those risks, the species would come to an end because dating would be over and all these other things would be, people would not go out and out of their house and if they didn't take risks. So we always take risks. And I put this in context of all those other risks. Anyway, so I guess my question is, I don't know. I guess my first question to you is, like, how do you think about life after the vaccine? What do you tell your patients? And those of us who've had to talk to patients, I think, like, you're going to have a real conversation. You can't say what you're saying on Twitter. 2, what do you think about the Twitter messaging and it's not just Twitter. I just listened to like podcasts from major news outlets, and they are really kind of on page with this messaging that nothing changes. The last thing I'd say before I turn it over to you is, like, some people make this argument of, like, and this is an argument that actually I never made, and I actually don't like this argument, which is like, if you message this way, then no one's going to take the vaccine, and if you message this other way, then people will take the vaccine. I was like, nobody knows, and we don't know what I don't know what you have to say to someone to get them to take a vaccine. What I do know is whether, this is the truth. That's all I'm saying. I'm just saying, like, this is the truth. It's an ultra low risk. Okay, so how do you think about this?
Okay, so first of all, I think that I think we can all agree, no matter what, that the risk completely changes, completely different ballpark after vaccine, right? Both for you and for the people around you. For the person who's vaccinated, definitively, there's been like 90,000 people who have gotten
on
some
trial. Yeah.
active SARS-CoV-2 vaccine. And I think 0 of them have been hospitalized. So of course, that's going to happen in the real world, but I mean, that's as good as it gets in terms of preventing a bad outcome. And then, in terms of protecting others, I think the original messaging was like, well, we just don't know. We just don't know, which, a lot of people who didn't really sort of understand the inclination in people who are scientists or medicine to that when they say they don't know, that doesn't mean that they don't have an idea about what it probably is, but it kind of means that it's a 50-50 prospect, right? And but the reality is that we do know, and there's mounting evidence that infections will decrease with these vaccines. We don't know by exactly how much, but by some probably sizable proportion, given that they're 95% effective against symptomatic infection, and some of the data that we're seeing from the Moderna study and from the AstraZeneca trial. And we also have a pretty good suspicion that you'll be less infectious.
Right. By virtue of the fact that you're not having full-blown COVID, coughing all over the place. Right.
And now there's viral load data to support this from the AstraZeneca vaccine. We can see this from natural infection. So and again, this is a virus that is transmitted, that has high dispersion. So there are few infections that cause most of the transmissions.
Right.
And so there's a pretty good chance that this probably gets you under the threshold for most transmissions. So, I mean, that's a little speculative, but we have good reason to kind of guess that that's the case.
Right.
So, part one is I think we can all agree that different ballpark in terms of the risk for you and probably for others too. And then the second thing is that the reality is people are already making these decisions, right? People are having Thanksgiving. People are going to holidays. And they're picking and choosing, and they're kind of making their own risk calculation. And some people aren't choosing, and they're going to these quote unquote essential jobs. And, and so people are already in these risky situations and are already making these decisions. And so I think that, to kind of pretend that the risk isn't in a different ballpark, or, to just say that things should be, which I think saying that things should be exactly the same is sort of in some ways saying that.
You're saying things should be the same means meet your grandkids, because that's what they're doing anyway. Yeah.
Well, exactly. But so I think people are already making these decisions. So the goal at least from a physician's perspective, talking to a patient, is to inform people, to empower them to make the best decision. And I think, to try to align it with public health in so much as you can. But again, I think we're probably to some extent exiting the realm of public health once you're reducing the risk by this much. I think there's still some unanswered questions about transmissibility, and people should still be informed about there's other tools that can be used to lower that risk should they want to. But I think ignoring the fact that people are already making these decisions and are already sort of making these risk calculations, it only serves to under-inform people. And so, putting that together, you have to, I think the reality is that of all the tools that we have, this is the best one.
Amazingly good.
It really, it's incredible. I think looking back, when over the summer, I was really worried that we were not going to have any vaccine.
Right.
Or a vaccine that really didn't work that well. I mean, when it was Pfizer that came, when the Pfizer FDA docs, that was euphoric just seeing that the Kaplan-Meier curves there.
Blew me away. I remember.
Go ahead.
I was just gonna say, I remember I think I was on some panel in June, and I remember being quite pessimistic, because we didn't know they're going to be successful or not. And I remember thinking I don't know, my mind goes to the classic oncology or, kind of world where what would happen is they miss the primary endpoint, symptomatic SARS-CoV-2,
right.
And then they pull some asymptomatic PCR ad hoc, some bullshit secondary endpoint and seek approval with that. That's what I thought they'd do.
Right.
But then they come out, well, first of all, they come out 3 days after the election, right? So I think it was November 9th when they hit the press release. And then I was like, oh boy, if they were 3 days earlier, this guy would be so much happier. And I was like, I almost feel like it's a conspiracy again. No. But I do, 3 days after. And then they came out with it. It fucking blew me away. I was like, I didn't believe it. And then when I got the pack and I read through it and I was like, can't argue. Because it was everything. It wasn't just symptomatic COVID went down. It was 0 hospitalizations, 0 deaths. All the things, like, I don't know, when people talk about like reading trials, and like so many times we argue about trials, a lot of the times we argue is like some of the endpoints go one way and some of the endpoints go the other way, and the drug has a marginal effect. Now you got a home run effect. All the endpoints go the same direction. Asymptomatic infection is going to be lowered. I don't know the answer, but it'll be between 60 and 80% is my guess. But I mean, the cumulative like lowered reduction in transmission, if I had to guess, I'd say 70, 80%. Like it's going to be, it's going to be on the upper end of it's going to be the glass more than half full. Is it going to be 100%? No. And if you're waiting for 100% to get your life, to go do some of these things, you're waiting for Godot. It's never going to be there.
Yeah.
I mean, I don't think that's going to happen.
The one other thing I would just add, because you were talking about sort of the messaging and sort of motivations for people, and just having had a lot of conversations with people over the years about vaccines.
Yes.
I think that in my mind, like the way that I would kind of put it very simply is that there's really no bad reason to get a vaccine, and people have lots of different reasons that they bring to the table. And it's when I'm in a one-on-one interaction with someone in the clinic, it's not my job to tell them what the reason is that they should get it.
That's true.
It's my job to have the discussion with them, and this is like sort of how motivational interviewing works. It's like what would motivate you to get this, and if you're having hesitancy about this vaccine, what is that hesitancy about, and what would motivate you to get there, and having that discussion. And so I think when the discussion is very much just around one thing that this vaccine will do. I've seen people say, well, like the vaccine is going to prevent you from getting COVID and getting really sick from it, and that should be enough. Well, I mean, for some people, that's the motivation. For some people, the motivation really is they've been isolated in their room for a year and they want to go see their grandkids. Right. For some people, it might be they want to get back together with friends. For some people, they want to feel safe being around their loved ones. So it's not really. I think that really to have the uptake that we need for this, I mean, we have to be open to all of these valid reasons that people might get the vaccine. And also, like that when we are very honed in on what the purpose should be, then I think that does open the window for people to be like, well, that's not for me. So that is my worry.
Yeah. And I think, I mean, I don't know, everything you're talking about is like, I don't know, all the things that you necessarily learn when you're like actually a doctor and have to go into the office and talk to people about actually getting these shots and stuff. And I've had a bunch of people just this week decide to get it. I think it's pretty close to 100%. I mean, because I think, when you talk through, I think people want to put this behind us. What I wanted to say was, you make this point about like vaccines, and I don't know. I never would have guessed when I was growing up. I mean, I grew up in the 1980s, and I never would have guessed that like in the 1980s, I don't think nobody thought twice about these vaccines. I mean, we were just getting the vaccines, and parents were happy to give them, and everyone was. I mean, I don't remember anyone ever saying vaccine to me other than vaccine great. That's the only thing I knew about vaccines. Then something happened. There is, I actually haven't followed it too closely, but there is a rise in the diagnosis of autism, and I don't know how much of that is underdiagnosed autism before and whatever after. And then there's this Wakefield paper, which is just total garbage. I mean, it's not even. I don't even know. Like people always like, oh, it was fabricated and blah blah blah. I was like, that wasn't the problem with it. It wasn't. It was always garbage. It was like an uncontrolled case series. It made no sense at all. I don't understand why they published it. Like even if it was all 100% truthful, I wouldn't understand why it's not even close to, I don't know what it was. It was just totally crazy. But something happened in the zeitgeist. I don't know, a few things came together. People were frustrated with the medical establishment because they didn't have a good answer for why their child may be displaying some of these symptoms of autism or autism spectrum disorder. There's this Wakefield paper. There's this, I don't know, maybe worsening income inequality and stuff makes you feel like less in control of your life if you can't live as good a life as your parents, things like that. And this strange anti-vax movement took off, and it like unites like super rich, wealthy liberals with like ultra right-wing conservatives. It's strange bedfellows in the anti-vax movement, right? Because it's like in Portland, Oregon, it's like thriving and like this like yuppie liberal thing. I think there, it has to do with, I don't know, feelings about GMOs, which by the way, the reason why like people don't starve, and like, and what is quote unquote natural. Anyway. All right. So this movement starts taking off, and I don't know this to be true, but I worry that it might be true that there's a reactionary movement of people who are well-intentioned and want people to get vaccines. And sometimes they get a little harsh. I mean, they get really combative and nasty, and they like insult people for being stupid, et cetera, et cetera. And I feel like, I don't know, as just an observer, because I normally don't stray into this space. I feel like it just gives them, it just fueling the other. They're just sucking up your anger, and the anti-vax is getting stronger, and the anti-vax is getting stronger, and you're like two poles of people just getting each other riled up. And the best thing we can all do is to de-escalate the hell out of it, and start to actually have some nuanced conversations like what you're talking about, where we don't treat. I never hear people say I'm anti-drugs or I'm pro-drugs. We talk about individual drugs and the risks and benefits, and we don't treat it like a monolith. And we should do the same with vaccines and talk about them. I mean, I was a little bit nervous earlier in this conversation because I was like, I don't know, saying this vaccine is better than the flu vaccine. I was actually a little nervous that that might be misconstrued as being against the flu vaccine. But I think, I don't know, that's just the honest truth. It is far less effective than the average flu vaccine, which I think averages in the 40 percentiles relative risk reduction. This is 95 percentile, and it's not an average. It's not going to bounce around because this is what it is. Anyway, I wonder what your thoughts on that are. That's not a question, but yeah.
Yeah, I mean, I agree with it. Just going back to again, principles of sort of like motivational interviewing, and bringing it into the clinic space, which is where I'm most used to it, and sort of how I think about the conversations in general, which is just telling people that they're wrong, never really results in you getting what you're trying to get. I mean, when someone comes in and you're like, someone comes into your clinic and they're like, well, oh no, I don't get the flu vaccine. And you just tell them they're stupid. That's really not going to accomplish your goal, which is to get them to get the flu vaccine. And so, I think in those situations, it's most helpful to kind of back off on your objective a little, be like, okay, I might not get them to get the flu vaccine, but I'm going to get them maybe to take one step closer to getting it someday.
Right.
And, understanding the motivation and just taking one little step towards that, because these come from deeply held beliefs and heuristics about the way that they're thinking about things. And, that's not something that you're just going to reverse in a second. And you get a sense of that, I mean, talking about vaccines with people and you're like, oh, you're due for your Prevnar vaccine. And they're like, what's that? And you're like, oh, it's for, this bacteria and blah, blah. They're like, okay, give it to me, or they're like, oh, they just want a little explanation. But then you see people who have very deep seated feelings and beliefs, and, you're not going to reverse that right away. And so I think that it's moving the discussion forward and having a conversation where you might ultimately get them to get there. And, and I think when it comes to the COVID vaccine, I mean, I'm certainly no scholar of, vaccine hesitancy other than just my own clinical experience. Right. But I do wonder just the people, I think that you were pointing out, there is this sort of movement with the Andrew Wakefield kind of, the people that kind of came out of that. And so I think that's a very specific, sort of, worldview framework. And so I don't know that the people who are hesitant right now to get this vaccine necessarily occupy that space.
Oh, that's a good point. Right. These are different. Right. Yeah.
But
totally different.
They may be coming from it from a very, very different perspective. And so I think assuming that that's where they're coming from is, may undermine, our role in having that discussion and being able to move them towards a vaccine. So, I don't know what the driving hesitancy is for among those who are hesitant right now, because I haven't seen good, very high quality surveys.
No high quality. Yeah.
I mean, the surveys are like, are you going to get it or not? But it doesn't get, and then there's some components of is it safety or this or that? But I mean, I think that sort of remains to be seen. What, one, truly how much hesitancy there is versus just are people want to wait a little bit to see what's going to come out? Or is it going to be the kind of thing where, some motivation may emerge? And I think that, it behooves us to not undersell the vaccine because, if people are, because, like you said, telling the truth about it is, and when you have a great therapy like this or a great preventative measure, you love to tell the truth about it. And I think that if that convinces people, great. I mean, it would certainly convince me. But
one of the things
so
that,
I think,
no, go on.
No,
I
go
mean,
ahead.
I agree with you so much. I mean, like, yeah, I mean, I'm just trying to, yeah, you just tell the truth. And the truth is that I think, like, most of us believe that it's going to dramatically reduce transmission. I mean, that's a damn truth. You know, it's based on the pretest probability of vaccines of this level will reduce it. And the one thing that I mean, you made this point earlier, which is like, quote, the we don't know point. But the thing that gets under my skin about the we don't know, we don't know that it's going to prevent transmission. And then I was like, you know, when you tweeted the selfie of you wearing the bandana over your mouth when you ran 24 miles, you didn't tweet, we don't know that this actually makes the world a better place. You confidently
Right.
said that wearing the goddamn bandana was going to make the world a better place.
Right.
So where did the confidence go? It's all gone now. Bandana. The bandana in the fucking mountain air, that got a lot of confidence. With this vaccine that's crushing it, that's not getting any confidence. And I don't know.
Yeah.
I find it interesting. It's interesting.
I mean, and I think that two things I think about that. One is that, you know, the mask is just really interesting because, you know, a mask is not a moral instrument, right? It is
now.
a tool.
There's the
It's a
cross and the
tool.
mask. You put them both on. Say your prayers.
And you know, I say this as an adherent to the mask. I mean,
Yes.
I think it's a great tool, but you know, it's not a moral instrument. And you know, I think the other thing you're seeing in that case is, you know, what's being termed like a visibility
Yeah.
bias,
Right.
where
Yeah.
you know, it's if you can wear it outside, and that, even though that's probably the least impactful thing you can do, I mean, you know, that is your signal that that you're fighting COVID, kind of thing. So I don't know. I mean, I was surprised by some of but I guess I was just surprised by how negative I sort of thought the vaccine messaging was, and I'm sure that comes from a lot of different places, but. You know, I mean, people are worried, and it's been a year, and it's been a really hard year to go through that. But that was something that took me off guard.
Yeah, I guess I was surprised. I guess I was surprised by the messaging, and then I was surprised by what I walked into. and I'm no stranger to getting getting beaten up, but I was a little surprised this time. This one took me off guard, and I do think that someday. You know, I'm going to be like telling people about this, and like with the distance of time, when you really have a lot of distance where people, you know, it takes away a lot of the emotion. And I'll be like, yeah, you know, people got really mad at me, and they're like, what did you tweet? What did you tweet? And I'll be like, well, let me read it to you. It's like, I want to write a children's book about a bear who doesn't want to go outside until it's perfectly safe, and he never goes outside and life passes him by. And then they're going to be like, and what did they say? And then like, I'll read the comments, and it's like, he's a fucking asshole, and he's like a horrible man, and indifferent to death. And I was like, oh my God. I was like, what the hell happened? I was like, it's going to be really quite a joke. But okay. Thank you for your time. This is fun.
Of course.
I guess the thing I want to talk to you about, or maybe I'll ask you the last thing, because I got a few more. I'll ask you last question. The global health side of your life. I guess I'm curious. I don't know if you have sort of a range of emotions on global health, because I don't know. I mean, literally, I do have this thought from time to time, and I don't tell too many people, but we're an hour into this podcast. No one's listening anyway. The thought I have is that it's so easy in 2020 to look back at, like, I don't know, the people who founded this country, or, you know, people in the 1800s, and be like, look at these horrible people because they didn't adhere to the moral code of whatever we think the moral code is. Well, I'm pretty confident that in 100 years from now, 1,000 years from now, people will look back on us and they'll be like, you lived at a time where, look at the difference. But if you happen to be born on this land, your life course is this. And if you happen to be born on this land, your life course is this. And they were so different, more different than anything, not justified by anything. And what did you do to stop that? And to me, global health is like, that's the root of it. The differences in health outcomes simply by where we happen to be born, something we have no control over. And I think future people will look back on it and be like, they will look back on us with the same sort of, I don't know, critical look we look back on prior generations for maybe not having done enough to stop bad things in their time. So, I don't know, whenever I meet somebody who's interested in global health, I'm always, very, I know we're going to get along on some deep level because I think we both feel strongly about this kind of, I don't know, fundamental injustice. But I guess my question is, the part I always think about is like, what is how you, and maybe what I'm curious about how you think about is like, what can a doctor do? Because I feel like, I don't know, if we really wanted to, the root cause of it is is the movement of capital and political processes, and how we strangle capital, we hoard capital in certain nations, and is all this aid and resources and global, from patent regulation and all these things that I think in many ways make it a lot harder for some of these nations to develop. Okay, but also there's role for providers. So how do you balance like being the doctor, the infectious disease doctor, who has a skill set that's obviously applicable all around the world, going in and doing medical work that makes the world a better place, and then also the work you do to try to think about the root causes of those medical problems and fixing those root causes? How do you think about this? And I guess what draws you to global health?
So I think that, fundamentally, one of the things that physicians and those in similar healthcare professions, bring to the table in this arena is that, we have the privilege of, being able to have proximity to people who are living in these vulnerable and marginalized settings that, and having them either come into our clinic or if we're going to their house and having them sort of, potentially if we have earned it, open up and let us learn about, what their existence is like and what it means for them to be in health or with illness or living with illness. Mm-hmm. And so I think that we have a window that doesn't really, come in a lot of other professions. So, I mean, even though it's not really, the definition of a doctor, and I think that, by the nature of the human interactions that we have the privilege to have, we have a window into understanding, some really important truths about the way that people live, which, people can write about from, far away and from, their nice houses in different countries or from wherever. But, really, unless you have proximity, I don't think you can truly gain any understanding. And I think it's a process. And I'm not saying I have all the understanding, but that I think is the fundamental strength of our role.
I see. That's part of your motivation. Yeah. Okay.
Yeah. No. So I think that that I think is very powerful information to bring to the table, and having that sort of person to person connection. And then I think that infectious disease in particular. I mean, infectious diseases. We're talking about things that are generally transmitted from person to person, or through an intermediary. But the transmission lines of infectious diseases generally run along with structural risk, things like poverty and food insecurity. And so, I mean, these things are fundamental to the way that infectious diseases work. I mean, there's a reason that you don't see, much cholera in the United States. You don't see a lot of tuberculosis, these kinds of things. So I mean, it's a fundamental aspect of the practice of infectious disease. So you can know what the antibiotics are, but they're not really going to be enough in most cases. Right. So that's sort of what drew me towards that, with my interest. And my particular interest, my research interest in thinking about the way that social protection and social safety nets, can actually be used to control epidemics. Thinking about it's not just about giving people with HIV their antivirals, because it's much, much more than that in terms of getting good outcomes and getting them to take the antivirals, then getting them to then have virologic suppression and not be at risk of transmitting this to someone else. And thinking about the ways that social programs and social safety net programs can improve those outcomes. So, in my mind, those go hand in hand, especially for something like infectious disease, but really with all of health in the world that we live in, I mean, these factors are important. So even if a doctor is not an expert in them, I mean, you have to work within the bounds of it, and if you don't engage with it, I think that you're in some extent doing a disservice to your patients by not just at least understanding that the framework within which we live. So I think that there's that aspect to it. And then I think thinking about, as you said, the world today is full of human beings, but then full of institutions that have been sort of perpetuated forward in time by our predecessors. And, and those structures and institutions are built in ways that have built the world kind of like the way it is. And so in our world, we have human beings who are good and bad and everything in between. But, there are these structures there that kind of, by the way that they've been built, have perpetuated themselves into kind of doling out value to some groups and less to others. And so I think, it's incumbent on us as citizens, not just doctors, but as citizens to think about ways to correct that, and to help, make it a more equitable world. And I think as a physician, we have the privilege, one, of being in that position to hear people and to understand what that life experience is like. But also, the reality is physicians have a lot of power, in our society and around the world. This is a profession that, people listen to you when you speak, for better or for worse. But, when you're speaking on based on the experience of patients who have, revealed themselves to you and kind of let you in, I think that you can speak from a place of knowledge on that. So that's like my general approach. I think at the end of the day, it's just about staying very, very humble and hearing those things and trying to just listen, because, this is not my life experience is not this one, because of this unequal world that we live in. And so, it's incumbent on me to make the effort to try to understand that, without bringing in my own sort of preconceived notions of what that is.
That's well said. Aaron Richterman, thanks so much. You've been listening to Season 3 of Plenary Session. Plenary Session is produced by Kiana Klossner. Music by Ian Straley and Audrey Tran. The views expressed on Plenary Session are those of whoever said it and no one else. Plenary Session is not medical advice. Follow us on Twitter at plenary_session. Until next time.